Today, I'm talking with Dr. Anna Glezer, who's a reproductive and integrative psychiatrist and founder of Women's Wellness Psychiatry, a clinic serving patients across California at the intersection of hormonal and life transitions and mental health, such as fertility journeys, pregnancy, postpartum, perimenopause, and premenstrual concerns. She and her team use a wide variety of tools, including medications, psychotherapy, natural remedies, and lifestyle medicine. This conversation was a quick one, but so packed full of really amazing insights and tips from Dr. Glezer about how you can first assess whether you have PMS or PMDD or something else called PME, and how to start to approach those from a very holistic standpoint, starting with understanding what's going on with your cycle, your hormones, how your lifestyle is affecting your mood, and then what you can do to go beyond that and really, who to work with to best support your mental health if you are struggling. The bottom line of this conversation was you don't have to be suffering. And I think that's a really key part of PMS because it's so over-normalized to say, oh yeah, I want to kill my husband before my period and all this stuff. But it really can negatively impact women's lives. And it isn't something that you just have to suffer through, even if someone has told you that. And there are a lot of solutions and a lot of tools that you can use. And again, this conversation really dives into how to really understand what's going on and then really how to approach it. So I hope you enjoy this. I hope it is really helpful. I think it will be. Dr. Glezer, thank you so much for being with me today.
Thanks so much for having me. I'm looking forward to our conversation.
Yeah. So I'd love to just learn more about you to start. How did you get into your specialty, which is sort of a unique field of integrative reproductive psychiatry?
Absolutely. That's a great question. And we can also chat a little bit more about what those terms even mean.
Mhm.
I actually have always been interested in women's health, more generally speaking. And when I was in medical school, I strongly considered going into OBGYN and did a number of additional rotations in REI, OBGYN, and lots of different kind of subspecialties. But I really felt like psychiatry was my passion. And so once I completed training, I actually went into reproductive psychiatry, which is the field of psychiatry where hormones and mental health meet. And so I work with a lot of individuals who are going through challenging fertility journeys, who are going through pregnancy, postpartum, who are having cyclical hormonal changes, maybe in the context of their monthly menstrual cycle, maybe in the context of perimenopause. And I actually began initially I worked at UCSF and I helped to found their OB psychiatry clinic, which was that reproductive psychiatry field. And then I really wanted to kind of expand what I was doing. And so I started a private practice, which is called Women's Wellness Psychiatry. And we actually serve patients all over California. We're able to do most of what we do through telehealth. And we really focus on those who are going through any of those kinds of hormonal transitions. And we use an integrative approach. So integrative psychiatry is the field of psychiatry that can use medications, and we often do use medications, but we like to pair that with all of the other tools at our disposal. So thinking a lot about psychotherapy, thinking a lot about lifestyle medicine, thinking about the role of nutrition and micronutrients for mental health, and really kind of putting all of those pieces together. And so really kind of looking at the person much more big picture and holistically and thinking about what are some of the root causes of what they're experiencing and addressing all kinds of different conditions, whether we're talking about anxiety or mood symptoms or trauma or anything that has to do with cognitive health, ADHD, all of those kinds of things, but also at the forefront, keeping in mind what is the role of the hormonal shifts on all of those different experiences and how can we optimize that relationship between hormonal health and mental health. And so Women's Wellness Psychiatry I founded to really bridge that gap because when even a decade ago, I think these days reproductive psychiatry is, even though the term isn't necessarily well known yet, the field is definitely growing. There's many more fellowships and things like that. But when I started, there was very, very little in the field, and there was a really huge gap, and there's still a huge gap, in my opinion, in specifically research on women's health and women's mental health. And I mean, so many even of our medications are tested primarily initially on male rats and then eventually on male patients. And so there's a lot of gaps, and I really wanted to kind of fill some of that gap, especially with the clinical work. And so that's what Women's Wellness Psychiatry does, is it tries to fill that gap.
Awesome. That's so amazing because even as you were talking, I was going to say there is such a gap still. Like I think, like you said, it's more maybe prevalent. They're more fellowships, but still, it's most psychiatrists are working in a very different field where it is more male centric. It is more like there's not a conversation about the hormonal shifts and what's playing into it and the root cause of it too. So I love that you're taking that approach so that you're really factoring all those things in and actually treating women as they are rather than just like kind of like part of them, like not factoring in a big part of them. That's really amazing.
Thank you. Yeah. And I think so many of our referrals are even from other psychiatrists who maybe didn't have the background in thinking about reproductive mental health and how to counsel their patients on all of those different topics.
Yeah. Yeah. That's awesome. So, there are so many different mental health concerns that we could talk about, especially when it comes to women's health, because we are more at risk for certain, mental health conditions, or they need to be approached in a certain way. So I think, well, I'll definitely have to have you back at some point. Today, we're going to talk about PMS and PMDD. And my thought about covering this today is, for one, it's so prevalent, but it's also one of those conditions that a lot of women just experience and don't really know if it's normal or not. And unfortunately, I think that they suffer unnecessarily a lot of the time. So I would love to hear your approach, maybe to start with how you would look at PMS or PMDD, and we can also talk about what those things are.
Yeah. I think to your point, oftentimes, whether we're talking about PMDD, whether we're talking about perimenopause, so many of these things are in that grin and bear it sort of mentality where you're just supposed to deal with it. And I think a lot of times our patients might get dismissed when they bring up some of these concerns as, well, there's not much we can do about it. Just, you know, move through it. But there really is so much that we can do. And I think the way that I look at it is if there's something that you're experiencing that's leading to a quality of life impact or, functionally impacting your work or your relationships or your life in other ways, then it's something that we need to address. And when we're talking about PMS and PMDD, there's actually three big categories that we think about. There's PMS, which is premenstrual syndrome, which is something that is often a lot of physical symptoms that maybe don't quite reach the threshold of that functional impact. But a lot of individuals can kind of experience that on a monthly basis. And then we have two other conditions, which we're going to call PMDD, which is premenstrual dysphoric disorder. And I can talk more about that. But even more commonly, because PMDD affects, about 5 to 8% of women, there's PME. And I think a lot of individuals aren't familiar with PME. PME stands for premenstrual exacerbation. And so that means if someone has a underlying anxiety issue or depression or bipolar disorder or ADHD or what have you, premenstrually, because of the hormonal shifts, those symptoms are exacerbated and they're experiencing a PME kind of condition. And both PMDD and PME can be really, really significant where they've actually done some research. Symptoms can get to the point where a significant minority, I think one study suggested it was 40-something% of those with PMDD actually experience suicidal thoughts in that premenstrual window. It's really, really challenging to go through that. And so I think it's important to recognize you don't have to just grin and bear it, so to speak. There's definitely so many different things that we can intervene on.
Yeah. Thank you for laying those out. So I think it's really helpful, especially the PME part, I think is not on a lot of people's radar. And that is really prevalent. I mean, at least I see it a lot as well. And it really is important, I think, to make that distinction of what are you dealing with, because the approach really is, in my experience, pretty different. And actually, I guess with that, how maybe classifying those out, how would you approach them differently then?
I think the important thing with PME is to make sure that whatever that underlying condition is that is worsened premenstrually is in really good shape outside of that luteal premenstrual window. So really making sure that whatever the anxiety issue or mood or ADHD, whatever the condition is, that it's actually, especially during that follicular phase, feels pretty steady and solid. And then really addressing the hormonal shifts and then treating it more like a PMDD. So we really need to make sure that the baseline, the foundation is in a good spot.
Great. And to start with kind of the integrative approach of like what maybe like lifestyle factors could someone consider when they are experiencing one of these things? Like where could they start with some of those changes there?
I think the very first place to start is tracking so that we actually know what we're dealing with and really having a couple of months of prospective tracking so that we can really capture what is the timing of all of this. Is this something that happens, 10 days before your period starts? Is it something that happens 3 days before your period starts? How long are your periods? How do we really kind of predict this? Because once we can actually predict it, we can really be much more thoughtful about the different interventions. And there's definitely a number of lifestyle interventions that can be helpful once we know what the timing is. And we can definitely also talk about those who might have irregular cycles and might still also have PMDD. And so how do we navigate that? Someone maybe with PCOS plus PMDD, those kinds of situations. But for those who have those regular cycles, one of the most helpful things is really just knowing that this is something that's on the horizon. The psychological mindset of being prepared and expecting something can make a big difference. And making certain kinds of interventions in your life for that preparedness. So maybe that means that if you have 5 really, really important meetings that need to take place, maybe we don't schedule those for the 3 days during that premenstrual window. Maybe we think about, rescheduling a couple of those. Maybe we think about, certain other important events. Maybe we change the different classes that we're taking. Maybe we're changing, which Pilates class we go to or what have you. Really just kind of knowing how to make changes in our life in anticipation of that and being mindful that, hey, I'm in this vulnerable window of time. What can I do preemptively as opposed to reactively? And just knowing that this is the stage can be really helpful also for relationships so that you can kind of be mindful when maybe you're feeling a little bit more irritable and how you're going to respond to someone. So I think the tracking and the preparedness is probably the very first and really important step. And then there's definitely other lifestyle things to be keeping in mind. Thinking about sleep, for example, and thinking about the role of actually getting sufficient sleep, particularly in that luteal phase when we think about the role of progesterone, which can actually be something that promotes sleep and then is kind of dropping off. How do we make sure that sleep is something that's protected? How do we think about, nutritionally speaking, making sure that we're getting the right micro and macronutrients to support our brain health? I think that's one thing that sometimes gets missed in a lot of conversations is, when we're thinking about those classic neurotransmitters that we often modify with medications, et cetera, all of those pathways to create those neurotransmitters require minerals and vitamins, all of these micronutrients to actually be cofactors in these processes. And so if we're deficient in any of these micronutrients, we're not going to be able to synthesize appropriate neurotransmitters. And it's going to also have a nutritional impact on our hormonal cycle and what our hormones are doing. So really kind of keeping an eye on the nutrition piece. And then also just being mindful of physical activity and thinking about, the appropriate levels of movement and staying active. There's actually interesting data on exercise for symptoms of PMS and PMDD and how that can be helpful. So there's definitely a lot of lifestyle medicine interventions that can be useful.
Yeah, amazing. And all this is music to my ears at this point because I'm like always telling people just track your cycles. Then the same way, if they're having physical symptoms or mental health symptoms, knowing when they're happening is 100% the most important first step because it could be, actually it could be something completely different going on with your hormones if it's a different phase. So that's an amazing reminder for women and to just like do those things of, I like the preparedness aspect of making sure things are dialed in so that you're ready and like at your best before those symptoms hit. And, maybe it's a lot harder then to do some of those things when you're not feeling great.
Exactly.
How about to go kind of maybe a step further, are there any like nutritional supplements or things like that you would then apply if someone is still struggling, beyond the lifestyle things?
There's definitely a number of nutritional supplements that can be helpful for those who are going through PMS and PMDD symptoms. And, just as always, a caveat, please make sure that anyone who's listening doesn't just automatically take a whole bunch of supplements. Make sure that you talk with your doctor about it. And the other thing about supplements that I always like to mention is it's really important to make sure that you're using a reputable third-party tested product that is going to have what you actually want it to have and not going to have any kind of additives or toxins or contaminants. So I always like to kind of give that umbrella caveat. With that, there's definitely some interesting data on certain vitamins and minerals and certain supplements that can help with premenstrual symptoms. From the vitamin mineral perspective, there's interesting data on combinations of magnesium, calcium, and vitamin B6. That combination has been shown to have an improved benefit for those who struggle with those symptoms. There's also some botanical options. Things like chasteberry, also known as Vitex, is something that has been shown to also help those who are going through difficult premenstrual experiences. So there's definitely some nutraceutical options that can be tried. And a lot of my patients might use those coupled with lifestyle medicine and sometimes even coupled with a prescription agent.
Yeah. And what's great about that is they aren't mutually exclusive. Like, you don't have to be like, okay, just everything natural and then nothing, sometimes we get pigeonholed, I think, into, oh, I'm just taking the natural approach. I can't do all of it. But it's a spectrum and a degree of, okay, what tools do you need? And they're all on the table. So it's great to line that out. And how about with medications then? Like, what pharmaceuticals then do you find most helpful for maybe each of these categories if they vary?
I think the main two categories of pharmaceuticals that are often used that have good research data behind them are those that are sort of in the class of SSRI medications. So those would be things like sertraline, fluoxetine, those kinds of medicines. And the interesting thing about those is, we typically think of these medicines as ones that, you have to take for 4 weeks or 6 weeks consistently to have an impact. But the data actually shows that these medicines can often be taken just during that luteal phase, specifically for treating PMDD, because of the ways that the metabolites of sertraline interact with the metabolites of progesterone, allopregnenolone, and it kind of takes this alternative mechanism and harnesses that. So we can really just dose them just during the luteal phase. And for some people, it's continuously, and we kind of have to be thoughtful about, is this PMDD? Is this PME? What are we treating? And then the other category are hormonal agents. So using certain kinds of birth control options, for example, combined oral contraceptives that can be helpful for managing symptoms as well. I think one of the main things with PMDD, and this is actually also the case for those who might be, for example, vulnerable in perimenopause, is that it's the delta that women are vulnerable to. I often get the question, can we test my hormones and see if this is something that's going on? And my general response is that's not going to really give you the information you need because it's not the absolute numbers of the hormones, it's the delta and how your body responds to that change. And so we can use things like combined oral contraceptives to really stop the cycling and stop the delta and therefore stop the sensitivity to that change. And so those are the two main categories. But then also for that category of individuals who have PME, premenstrual exacerbation of something that's underlying, what I like to do is just be thoughtful about what are you taking in general, and can we optimize that during that luteal phase? And so there's interesting data, for example, on sometimes needing a slight bump in dose of a stimulant medication for someone who has ADHD where symptoms worsen premenstrually, or certain other medications that we're already using the rest of the time. Can we optimize them during that time?
That's great. I feel like that's so probably really helpful for a lot of people to hear because there is a lot of thought that I've noticed where people feel like, oh, once I get on an antidepressant, I'm never getting off of it. It's going to be really hard to get off of it. And so being able to say, yeah, you could do it just during the phase that you need it, or you can have an adjustable dose based on what you need. It is flexible. It isn't an all or nothing thing that they're locked into.
Yeah, it's really important to have an individualized approach.
Yeah, absolutely. And with that, are there any special considerations when you're choosing a medication, especially in this population when we're talking about these reproductive years, if someone could possibly get pregnant, if they're trying to get pregnant, they're also having these symptoms they're trying to deal with? Are there any considerations there?
I think the important thing is that there's very few medications that have absolute contraindications from a psychotropic medications that have absolute contraindications for pregnancy. So many of our medications are actually ones that we often do continue in pregnancy, because what we need to have is what's called a risk-risk conversation, right? We're not talking about just the risks and benefits of the medicine. We're talking about the potential risk of medication, but also the really significant potential risk of untreated symptoms, which can have its own host of negative consequences. There's data on the complications of untreated depression in pregnancy, for example, and untreated anxiety, and differences in obstetric outcomes and postpartum experiences, and so much data and research there. And I think we often get lost when we're just focused on the medication, and we need to take a step back and think about the fact that this is a big picture, risk conversation. And we actually do have so much data on some of the most common medicines, like the SSRI medications, the sertraline, the fluoxetine, the escitalopram, on the reproductive safety of those medicines. And contrary to some of the recent conversations, the unfortunate recent conversations at the FDA national level on this topic, more and more bodies of actual clinicians are coming out with, I know ACOG put forward a statement, the American College of OBGYNs put forward a statement in support of the use of SSRI medications in pregnancy. I know many other bodies of clinicians who actually are familiar with the research and data are also in support of the use of these medications, because the consequences of not using them is so significant, and we need to weigh both of those. And so I can't even count how many patients who've been able to successfully continue on their medications through pregnancy and through postpartum, and have healthy pregnancies for mom and healthy pregnancies for baby, because their symptoms are really well controlled. And we don't need to, we always need to think about, in any reproductive age woman, what is the potential for pregnancy, but that doesn't mean that we eliminate so many of these different options.
Yeah, that's so good to hear. And it's a common conversation that I hear too, especially when I'm helping people get pregnant. They're so concerned about anything getting in the way of their chances, which I 100% agree with. And, I understand where they're coming from, but it's great to have that reassurance of, hey, not anything that's synthetic is going to be dangerous or whatever. And like you said, the risk of having certain symptoms untreated could be potentially very dangerous for them, or just terrible and really not fun for their entire pregnancy if symptoms even get exacerbated during that time.
Exactly.
So
Yes.
wonderful. Any other tips that you'd like to leave people around this, around dealing with mood, especially in the premenstrual phase?
I want to also just emphasize the benefits of psychotherapy, and the fact that there's so many different styles of therapy, some that are much more skills-based that could really help folks focus on, if, let's say, during the luteal phase, they have a lot of trouble with emotional regulation skills or tolerating distress. There's certain types of therapy that can really target that. And there's, other forms of therapy that can really address whatever someone is going through. And so I think the psychotherapy piece is a really important part of that kind of comprehensive integrative approach. And it can take time to find the right fit and the right psychotherapist. You're not always going to marry the very first person you go on a date with. And so that means that also, finding the right psychotherapist can take time. But I think it's really worth to, invest that time and energy to find that fit and connection, because that person can be really, really beneficial. So in addition to the lifestyle options and the nutraceuticals and the prescription tools that we have, I think the psychotherapy piece can be really valuable as well.
Yeah, that's a great point. I've seen at least a few studies that say that CBT, even the regular talk therapy for the layperson, can be really beneficial for PMS symptoms. And with that too, there are so many different modalities when it comes to psychotherapy. Is there one in particular that people should be choosing, or is it really just what the right fit of the practitioner they're working with and the tools that they have?
So the latter in many ways, because they've done some interesting studies where they've looked at the style of therapy versus the rapport with the therapist.
Mhm.
And rapport with the therapist is the number one thing that helps folks get better.
Mhm.
And, all other things being equal, then yes, you can kind of choose depending on what style might resonate with you. There's certain styles of therapy that are particularly good for helping those who've gone through trauma, or, certain folks who might have just a lot of like negative spiral thinking. So lots of different styles depending on what you're struggling with the most. But first and foremost is really finding that connection and that fit. And there's so many different styles. It might be a matter of kind of trying things out and seeing what resonates, but really finding that right fit, that connection is going to be the most important part.
Yeah, definitely. Yeah, I can't tell you how many patients I've had come to me before. They're like, oh, I mean, a lot of people actually, more often than not, people have positive experiences with therapy, but there have been so many times where like, well, I tried that. It didn't really. And I'm like, okay, try something else, because it isn't like it is that they went on one date and they're like, well, I'm never going to get married. It's not for me. Definitely there are so many different practitioners and styles out there.
Yeah, yeah, exactly. You have to give it another chance.
Yeah, great. And I feel like that, again, we've touched on so many different of these like tools that people can draw from. And with all of them, it's finding that right fit for them of seeing, what aspects are maybe not completely optimal. Is it their sleep? Is it their diet? Is it they're not moving enough or too much or whatever? And then finding the right fit with a team as well of, maybe a practitioner to use the medications if they're necessary, a therapist, if they're not one and the same, to then, also give that support.
Yeah, and I think the main point is not kind of suffering in silence, so to speak, but really, if this is something that's functionally impacting you, then reaching out and getting the support you need. And if the very first person that you connect with isn't necessarily resonating and not hearing you and not validating your experience, well then, finding that right fit with someone else who's going to help you put together this kind of comprehensive treatment plan. And it's often, in my practice, we have psychiatrists, we have psychotherapists. We often collaborate really closely with OBGYNs, and then with so many other, primary care doctors and many other clinicians to create that kind of team-based approach that I think is really important.
Yeah, definitely. I completely agree. With that, any last tips you'd like to leave, or, action items that people can start with? We haven't, again, I think a lot of this has been very approachable. We've offered some great tips, but anything else?
I think, again, starting with learning more about yourself and your cycles and your hormones so that you can be educated on you and how your body works, getting all of that information so that I think knowledge can be very empowering. And when you have all of that knowledge, you can then take it to the next step and connect with the right support.
Yeah, absolutely. And where can people find you, Dr. Glezer, in your practice? It sounds amazing and dreamy, and I'm already referring people to you, of course, but
Would be happy to see them. If a patient is in California, we are licensed throughout the state of California and can schedule a free phone call with me directly on our website, which is annaglazermd.com. And also, I have a podcast that I run, a couple of episodes per month, which is Women's Wellness Psychiatry Podcast. You can find me there, and really just find me in many different places around social media and online, and I'd be happy to connect.
awesome. Well, thank you so much. And again, I was so excited when I learned about your practice and you, and it's such a great resource, especially, I mean, obviously we're both in California, so I get to refer to you and everything. But I think we need more people like you to give this kind of support. And so I'm grateful for what you've done.
Thank you so much.